I'm Jonathan Kay from University of Massachusetts Chan Medical School in Worcester, and I'm here at ACR 2022 Convergence, and I'm with Janet Pope from Western University, Ontario.
That's right.
And she just delivered a remarkable performance at the Great Debate.
Why, thank you.
The Great Debate today was about whether to treat pre-rheumatoid arthritis, and Kevin Dean and Mike Holers from University of Colorado were pro, and Hani El-Gabawi and Janet were the con.
That's right.
And you delivered a very convincing discussion about how a patient would respond to treatment.
So we thought it'd be kind of fun as well as informative if we sort of thought from the patient perspective, you have a positive test, you have some pain. We don't know if the pain was anything to do with the reason why the test is positive, and we made it even that you had a family history of an aunt with RA. So we made it that it could be plausible that this person's at risk for RA, but it was the thinking as well as what was said that I think was both entertaining and educational.
I loved
yes.
it. You had the text of the conversation, but you also had clouds with what each person was thinking, and it was brilliant.
Well, we thought too that I think the debates traditionally, although it's important to have learning and science, I think it's expected that there is a little bit of humor that really illustrates the point. And I must say, Hani thought that up, and I thought it was brilliant too.
And the science is there, and you both had the same science. Kevin and Mike and you and Hani, you agreed about the scientific background. The question was, can you determine pre-RA at a time before rheumatoid arthritis has started and truly prevent rheumatoid arthritis as opposed to treating rheumatoid arthritis very early on?
Right, and I think the studies a lot are actually RA that doesn't meet criteria, or arthralgias with sometimes even bony erosions by MRI or ultrasound. So wouldn't you think that they're RA as opposed to pre? That's the first thing. And the second thing is if we look at people at risk of diabetes, so we say pre-diabetes or IBD, but they don't meet criteria for Crohn's. I think a lot of chronic diseases that we could look to have the same idea. You've got something going on, you don't have a label, and we could overtreat, or if we knew we could treat and make things better, we'd probably all, and if it was a reasonable, well-tolerated, well-afforded treatment, we'd probably all jump on it. And that's where we're at right now in pre-RA. We really don't know. There's a spectrum. Not everyone at risk obviously will ever get RA, and some people will. So the risk of overtreatment versus no treatment is there.
Well, one of the problems with pre-RA, and there's now a diagnostic code for pre-RA, is that the approach to treating pre-RA is really using rheumatoid arthritis treatments to treat a completely different disease. And if you look at patients, about 1 in 5 or 1 in 6 of anti-CCP positive patients are going to develop rheumatoid arthritis, but do you treat them with an RA drug, or as Mike Holers suggested, perhaps a drug that's directed against the inflammation that's occurring in the lungs or in the gastrointestinal tract or in the teeth or the gums to treat a completely different process.
Right. So who knows? And I mean, it's not even in a way a disease. The way RA is a spectrum of things. And at a cut point, it's like the day before, did you have RA or not? Well, obviously they did in a chronic disease. So I think there needs to be a lot of research. And I think that's what the debate actually brought out is we agree we need research and we need trials and we need to know the natural history of all those people who aren't going to get RA, who have positive ACPA and or arthralgia with it.
And it came out that glycosylation of ACPA might be a more sensitive biomarker to predict who might really go on to develop rheumatoid arthritis.
Absolutely, and also where it's coming from. There were some talks yesterday of sputum, IgA, ACPA might be far more predictive. But the other thing is once we have tests in the open marketplace, so to speak, you can get a lot of false positives. You can get true negatives, false negatives, but a lot of false positives. So I think we have to be aware that we wouldn't want people treated with drug X under diagnostic code Y that don't even have anything.
And an important point that you brought up is related to the manpower issue or the person power issue, that there aren't enough rheumatologists to deal with the 400 requests for new patient appointments now, and if you have an increased number of asymptomatic individuals with positive tests, we might not right now have the manpower to deal with
That's right.
that.
And we don't know what to do with them anyway. And the way I would think about it when I talk to my trainees, an ACPA might become eventually the ANA, which is the thorn in our side. Positive ANA done for the wrong reason is 100% irrelevant. So hopefully we won't get to that in RA or pre-RA.
Right. Well, at least at this meeting, we're learning that hydroxychloroquine has no place for the treatment of the pre-RA patient.
Unfortunately.
And we're learning much more about this very important area, and I look forward to much more information about this at this and future meetings. And for more information about this and other topics, join us at Room Now for further coverage of ACR Convergence 2022. Thanks, Janet.
Thank you.